Hello, so again, rapid review cardiology. Welcome all of you. Only a few hours are left, I should say. So I decided to give you a view of all important ECGs today. The ECGs which may be asked in the examination, in your clinical practice also, and one should have a very good knack of reading the ECGs because it plays a very important role in the diagnosis of cardiovascular diseases. So I will show you a few ECGs and will describe them. So I have written the diagnosis so that you can very quickly, because this is a quick review rather than a quiz sort of thing. So you can see very deep T inversions in the precordial leads. This is apical kind of hypertrophic cardiomyopathy, which is also known as Yamaguchi. This is more common in Japan, that is 4% and only 1% in other countries, including the European countries. So it's a very important ECG. Oh, this is also the same. So we will go to the next. So the first degree heart block here with the septal hypertrophy, important one. You can see the Q waves and a right bundle branch block pattern and a left axis deviation very clearly seen. A tall R wave in lead 1 and a deep S wave in lead 3. So the left axis deviation I wanted to show you, and a right bundle branch block pattern with the first degree heart block also marginal. So we may call it as a trivesicular block. This is second degree heart block. Every alternate P is not conducted and not giving the Q. So these P's here, this is not conducted and this P is conducted. So it's a second degree heart block and the PR is not changing. So it is type 2 MOBIS. Second degree with a transit complete heart block. You can see these tracings where no P wave was conducted to ventricles. See this one, this area, first of all in the tracing, and it's a very good ECG that way. That was a transient complete heart block. Hypercalcemia doesn't have ST segment, I should say. The whole of the ST segment is abbreviated just after the S wave. There is no ST and there is a T wave. Very good ECG, you should keep it in mind. Hypercalcemia may be associated with hyperkalemia also. We will show a ECG picture later on. So interval MI, which one? 1 and AVL. So this is the one important ECG that way. And there is a slow progression of R wave. There are reciprocal changes in second, third and AVF. A good picture that way to remember. Acute anterolateral MI. Again, only V5 and V6 here. So keep. There is a old infarction here also in the third AVF and V5, V6 there is a ST elevation. Keep this in mind. Good one, acute extensive interval MI. You can see such a good picture. 1 and AVL is also involved. So extensive interval MI with the bundle branch block pattern. So this is a very proximal LAD occlusion. Inferolateral with posterior because there is a ST segment depression in V1, V2, V3. A good picture that way of acute inferior wall MI second, third, AVF and V6 inferiolateral as well as the ST depression, which is a mirror image of the posterior wall leads. If you want to see direct, then you will have to take V7, 8, 9. Pericarditis, with which the myocardial infarction is very frequently mistaken. So you can see the pattern here, concavity upwards, and only one lead shows, or say two lead shows, the reciprocal changes. So the PR segment elevation here in AVR and the T wave inversion. Otherwise every lead shows a ST elevation of concavity upwards. A good ECG should keep in mind. Atrial fibrillation with such a heart rate, very less heart rate, always keep a complete heart block in mind. AF with RVH. So maybe there in the cases of mitral stenosis also. So the AF has taken place. Which are the leads to see P wave nicely, and particularly the fibrillatory wave? Lead V1. You can very well see the atrial fibrillation here and the complete and the RVH picture. I am very sorry about this. So AF, atrial fibrillation with a left bundle branch block pattern, should always be kept in mind. It is not a ventricular tachycardia. Such a irregularity doesn't happen in ventricular tachycardia. So atrial fibrillation with white QRS with such a irregularity, never give AV nodal blocking agents. Otherwise, the patient will land into what? Ventricular fibrillation. All the atrial fibrillatory waves will be transmitted to the ventricle and patient will collapse. So I have shown this tracing only for that purpose, that this is atrial fibrillation with a WPW response, a bypass tract conduction. So keep this in mind. If there is a ventricular tachycardia of this irregularity, never give AV nodal. This is atrial fibrillation with WPW again. This is another tracing. See the rate, such a high rate. If it is transmitted to the ventricle, there will be a cardiac standstill. Again AF with WPW to emphasize to the fact to you that it is a very dangerous rhythm. Never give a AV nodal blocking agents, because then all the waves will be transmitted to the ventricle through the bypass tract. Very important ECG again. Flutter with left bundle branch block. Important to see. One P is clearly seen, another P is behind the QRS complex. This kind of regular thing with some P waves available. Never forget a flutter. The rate is very high. 2:1 block. Most common flutter. You can see it here. Where are the P waves nicely seen? Second, third AVF and V1. V1 is very nicely seen. One P is not conducted and one P is followed by QRS. The atrial rate of around 300 or something, and the ventricular rate of some 150. Atrial flutter with variable block is always confused with what? Atrial fibrillation. So very good ECG that way. Variable block looks like a ventricular atrial fibrillation. After conversion of a AV and RT, you can see the R wave is normal here. We will show you the AV and RT picture. Anterior MI with right bundle branch block. The terminal R wave here, very important to see. Such a kind of ST elevation. It's a very proximal ideality block which has caused this. Interval MI picture of some duration. You can very well see not one, but the AVR, V2, V3, V4. Very good picture that way. Keep always these in mind. What is this? There are some fibrillatory waves. No. It's an artifact in a patient of Parkinson. Never forget this also, because you may misdiagnose the patient. There are two pictures, dangerous I should say. Both of them lead to ventricular tachycardias, syncope or sudden cardiac deaths. Very classical picture in V1, V2, V3. ARVD. Just see a wave here, epsilon. This kind of wave, a elevated S wave here, followed by a long here, this which I have given with the arrow. Always nice to see, important to see, an incomplete RBB type of picture. ARVD, arrhythmogenic right ventricular dysplasia. The echo is very diagnostic. Brugada, echo is normal. But this kind of cooing, type 1, never ever forget. This is Brugada. If you see it in the lifetime, you will never forget this picture. This one. Very important to see. Both of these conditions may lead to sudden cardiac deaths. So ASD with pulmonary hypertension, RVH you are seeing. Right axis you are seeing. And this is a case of ASD. Keep this in mind. Such a right axis, deep S wave in lead 1 and a R wave in lead 3. Extreme right axis I should say. Right ventricular hypertrophy you can very easily see here. So ASD with pulmonary hypertension here. Atrial tachycardia with 2:1 block. Important to see. Digoxin toxicity, most of the cases. I have shown you, I have kept this tracing for you to see the lead 1, where the P waves are very nicely seen here, and the 2:1 block is very clearly seen, my dear. Never forget this also. But this is usually the toxicity of digoxin. So AT with 2:1 block again, and a very good picture that way, that the every bit two P waves are very clearly seen, although one is obscured by the QRS complex. NRT, pseudo R waves, where? Very clearly seen here in V1. And after the conversion I showed you the picture, they are. Here also the P waves are seen. These are inverted P waves here. If you see them clearly, carefully I mean, then you can see them in second, third AVF and a pseudo R wave in lead V1. Very good picture to show you the AVNRT. Again this is a AVNRT, good picture, pseudo R waves, very nicely visible in V1 lead. And here there are inverted P waves in second, third AVF. Benign early repolarization BER, important to see. Never confuse it with any pathology, and particularly seen in the lateral leads. A bifascicular block here, right bundle branch block you can see, and a right axis deviation. Important to rule out other conditions before you comment a right axis deviation here. And here I can see the PR is also prolonged. This is more or less a trifascicular block and will require a pacemaker implantation. A cardiac tamponade picture. Such a low voltage, very good ECG that way, and a electrical alternance here. So the good one to see, such a low voltage that is less than 5 millimeter in the hexagonal leads and less than 10 millimeter in precordial leads. So good one. Low voltage with electrical alternance. Tamponade. Complete heart block. P waves and QRS are altogether different. So never forget this. Complete AV dissociation. COPD picture with a core pulmonary sort of thing. You can see them. For P waves I have shown you this picture. P's are pointed. And you can see here in V1 they are not that broad and bifid pictures. So this is a good ECG that way. It's a COPD1. Never confuse. Again a COPD1. The P waves you can see in second, third AVF. Very nicely seen here. They are inverted in V1, but they are pointed sort of thing. Dextrocardia. There is a decreasing R wave pattern in the precordial leads. And you can see the picture here. Everything is inverted in lead, standard lead 1. And AVR is just looking like a standard lead 1. So it's a dextrocardia. The heart is on the right side of the chest. Hereditary long QT, very prone for sudden cardiac deaths. This I have kept you. If you just, what is the upper limit of QT? 0.45. For ladies this is 0.43. For males it is 0.43. It's the upper limit. And for females 0.45. So how many small squares here? 12, 13. Anything more than 10, 12, you know is 0.4. If you count them, then this is a prolonged QT. Very important. Patient may lead into a sudden cardiac death. Hyperkalemia, stage wise. Just see. Tall T first. Then much more tall T. Important to see here. You can see. This was mild one. Starting of the T tenting. Then this was the moderate one. More T's. And P's are disappearing slowly in the moderate one. And the sine wave pattern ultimately may lead to arrest. So this is the very severe hyperkalemia to the level of around 8 milliequivalents or so. Good to see, never to forget. I have shown you the 12 lead also. The sine wave pattern here may be confused with ventricular tachycardias and other dangerous rhythms, but to realize hyperkalemia is very important. Inferior wall, the MIs can also be accompanied by pericarditis, and this is one picture where there is a pericarditis also and the inferior wall MI is there. A good picture that way. You can see the other features of pericarditis. The PR segment elevation in AVR is very clearly visible here. In hypertension cases, see the LA. This is LA enlargement with the more negative segment of the P in V1. Very suggestive of left atrial enlargement. Left ventricular enlargement by voltage criteria is very nicely shown here. Left bundle branch block with a first degree heart block. While left bundle branch block, see the V6 very clearly seen. See the lead 1 nicely seen. See the ST elevation in V1, V2. Left bundle branch block and just count the PR interval. It is 0.24 or something. Left lateral bypass tract. How do you know? The delta wave in lead V1 and V2. Classical picture here. I can see this. That is a left lateral bypass tract. The most common of all the WPWs. Multifocal atrial tachycardias. In a case of COPD, acute exuberation, you can see the different P waves here of at least 3 morphologies. Very nice picture that way, and you can see in the V1 all the different types of P. So 3-4 different types of P and a tachycardia is very suggestive of multifocal atrial tachycardia, may lead to atrial fibrillation also later on. Another multifocal atrial tachycardia. Keep this in the mind. 3 P wave morphologies at least, if not more. Monomorphic ventricular tachycardia. Don't forget, this is the picture. Such a wide QRS. In one look, you should be able to recognize this picture as a monomorphic ventricular tachycardia. Mitral stenosis in sinus rhythm, rarely seen, but you can see the left atrial enlargement here, a good one here. This is a case of mitral stenosis, and you can see that when the patient is in sinus rhythm, it's very well seen that the left atrial enlargement is there. MS and MR both, left atrial enlargement as well as the left ventricular hypertrophy also. This is also important of double disease of the mitral valve. This ECG you may really misinterpret it as a ASD or something, because there are T-wave inversions in V1, V2. Never mind, in this age, this can be a juvenile pattern. Orthodromic ABRT, that is a WPW, and you can see the P wave being following here. See the V1 and how nicely the P wave is there. I have taken this tracing particularly for you people to visualize this P wave in V1, which is following the QRS. So the important thing, and there is no wide QRS with such a high rate, because the antegrade conduction is through the AV node, his bundle system. Old anterior wall MI with right bundle branch block with the first degree AV block also, a good picture. AV block, first degree AV block, it's quite a long PR interval, and a right bundle branch block, terminal R wave, easy to see, there are big Q waves. So never forget, a right bundle branch block with anterior wall MI. Inferolateral MI, you can see Q waves here and Q waves in V5, V6. Good picture that way. Posterior wall was not involved in this case. Again a hypothermic patient. There was a snowstorm, and after that the patient landed in ICCU with these waves, Osborne wave. If you see them once, these are the J type of waves. If you see them once, you never forget in your life. Osborne 1. It's important to see a rectal temperature in septicemias or the therapeutic hypothermias. The patient may land into troubles, a standstill, if you don't take care of this. So rectal temperatures are important. Old inferolateral MI, nice to see here. Oh, the same picture, I am sorry about it. Pulmonary embolism, a good picture. S1Q3T3 is partially seen here, I should say. That's why we took this picture. S is a very good wave here in lead 1, and you can see the classical pattern in lead standard lead 3 and a RV strain pattern, not a particular strain pattern, but the S1, S2, S3 and a right incomplete right bundle branch block pattern, which is a pulmonary embolism with such a sinus tachycardia. Pulmonary embolism again with a RV strain pattern. Good one to keep in the mind. This RV strain and tachycardia with the right axis deviation. The only diagnosis is pulmonary embolism. Again a pulmonary embolism. Oh, I am sorry. So it's again a WPW. You can see the delta waves in many leads, including the one AVL and lateral leads here. It's the septal tract which was seen. So the prolongation of Q here, you can see the hypercalcemia, there is no ST, and in hypocalcemia such a long ST. For hypocalcemic ST only I have taken this picture, and this is the normal one. So never forget this. Prominent U wave in hypokalemia is very important. You can see the prominent U waves are seen in the hypokalemia, which can be dangerous and may be the harbinger of ventricular tachycardia, and many things may happen after the loop diuretics. So the important picture that way. You can see the U waves here very nicely seen here in between this. So this is also the one hyperkalemia we were talking. The QT prolongation here, hypokalemia I showed you just now, and the tricyclic overdose, very important. The right axis deviation and R in AVR with this picture. Never forget, my dear, tricyclic antidepressant overdose is also such an important thing. In the same way, hypothermia, I have already shown you the J waves, so called the Osborn waves. Amiodarone, the QT is prolonged here. Subarachnoid hemorrhage, these types of QT also prolongation, and deep T waves, very classical of subarachnoid hemorrhage, although they may go into ventricular tachycardia. And long QT is accompanied by what? Torsade de Pontis, very important diagnosis. Always keep that in mind. In renal failure, I am showing you because of the hyperkalemia also and hypocalcemia also. This is an important picture here. Hypocalcemia, prolonged ST segment and such a T. In a renal failure patient, this is a good one. Bypass tract again, right one, because there are delta waves in lateral leads like V5, V6, 1 and AVL. So very important one. This is a right sided bypass tract accompanied with Epstein anomaly in this case. It's a six sinus syndrome. Such a bradycardia, there are hardly Q waves in whole of the thing. P waves also you don't see. It's a complete sinus arrest sort of things in between. This is a part of six sinus syndrome, such a bradycardia. Innocuous ECG, sinus arrhythmia. You may feel there is some problem here, but no. This is respiratory variation in sinus arrhythmia in a young boy, and this is a normal ECG. With the inspiration, you can see the crumbling of QRSS here. The change must not be more than 10%. With a premature complex, not a very big stuff here, but I have shown you this picture for the RBB and some pathological Q waves and ST elevation. Such a nice thing to see in anterior wall. Again a right bundle branch block pattern. So I am repeating this to keep these in the minds. Tricyclic and antidose are in AVR with a QT prolongation, with a sinus tachycardia, anticholinergic effect, tricyclic antidepressants and cocaine abuse. These two things must be kept in mind. Never forget them. Monomorphic tachycardias, repetitive. Very good picture that way. This is the picture of monomorphic ventricular. VTs, several types of VT. We read them one by one. The first one is the dissociated P waves, but this Vt very clearly visible. In the same way, the B1 is a flutter sort of thing. These are all part of Vts and Vfs, but keep these in mind. This picture may also be there, and this is a ventricular flutter. Never forget. Number 3 is a sinusoidal Vt due to electrolyte problem, hyperkalemia. This one, D1 is the polymorphic one, screw pattern, change of axis of the ventricular tachycardias, and this type of rhythm. And the ventricular fibrillation, this kind. Never confuse with the artifacts, but this rhythm is such a scary rhythm. So the all of types of the ventricular tachycardias I have shown you here. Again a WPW pattern here, maybe posteroseptal here, maybe, and you can see the delta waves in V5, V6, 1 and ABL with such a wide QRS.